All right, everybody. Welcome back to another TraumaCast. Brad here, the trauma manager, excited to bring another episode to you all. We got a good topic today and a good group of people here to talk about it. As always, I'm joined with Joanna Kim, our illustrious educator and QI coordinator, and Dr. Burd, our attending and medical director for the trauma service. We got some other new faces here that we're super excited to have because today we are talking about leadership in the code bay. So, how does everybody's role be affected by good leadership styles, poor leadership styles, and why is it so important to maintain some level of leadership? So, at first, I think we'll start with Dr. Nickerson. You want to introduce yourself to the group?
Sure. Hi, thanks for having me. I'm Dr. Nickerson. I am a pediatric emergency medicine attending at Children's National. And I'm so excited to talk about leadership because I feel like at the head of the bed, at the foot of the bed, it's my job to make sure that everything that needs to happen right now is happening.
Absolutely, and we definitely that I think that's a good point to bring up. And then we also supporting our nurses. We have both Joanna, who has helped out in the trauma bay as a primary nurse, but we also have Jess Tobin. Jess, you want to introduce yourself?
Sure. I'm Jessica Tobin. I'm one of the clinical educators in the emergency room. I'm one of the charge nurses and bedside nurses working in the trauma bay.
So we all kind of have both this doer and kind of teacher mentality. Dr. Nickerson works very closely with our fellows and our residents. Jessica and Joanna both really support both our like new nurses inside of the trauma bay as well as our continuing education needs, because this stuff isn't always something we see every day, and so it's super important to have folks like you at the helm here. So I think we'd start with just doing a little bit of role understanding for those of you that are either new to our institution or from outside of our institution, just talking a little bit about what each person's role is when the trauma comes in. So, Dr. Nickerson, you want to start with kind of what the attending, the EMTC attending and fellow kind of do and how they prepare for that call coming in?
Sure. So, as the emergency room attending, we often are the ones who take the calls from EMS. So we'll hear about the trauma before they come in, and take the lead on making the call for whether they come in as a trauma stat or trauma stat attending or don't meet trauma criteria. And then once the trauma comes in or the team assembles in the room, we share that information, what we do and what we don't know, which is often a lot, with the team at hand. And I try to take that time to set up priorities for not only the regular stuff that we do in every trauma, the ABCs, but sort of focusing the team for the key priorities for that patient.
Yeah, absolutely. I think creating a baseline of understanding is one of the most important roles because you guys are obviously already in the unit, and so you're one of the first ones to start as people start to gather. The one benefit to being in a level one center is we have trauma surgery as part of our response, and so Dr. Burd, you want to touch on the surgery? So we have a surgery fellow who comes in, and then depending on the call, we also have an attending. What are your all's roles as you kind of enter that call when it comes into the bay?
Yeah, I mean, I think our expertise is bringing in the surgical perspective, and that is sort of unique. We bring our adult trauma experience to the trauma bay. Our residents bring that experience to the trauma bay at all levels. Our junior residents or senior residents and our fellow have quite an extensive experience that they bring to the trauma bay. But one of the things that we hopefully also bring to the trauma bay is the ability to lead together with other members of the team, and I really think that's sort of a critical skill that we need to learn. A lot of our team members come from places where the adult trauma surgeons basically run the entire room for all trauma patients in an adult setting, and we have something very different in the pediatric setting in the children's hospital, where we need to work together with pediatric providers because there's a unique set of experiences, just like we bring a unique set of experiences from our trauma experience and our surgical experience. They bring a unique set of experiences of their pediatric experience. So if we figure out a way to work together and lead together, we can find the best way to get the best outcome for patients.
Yeah, for sure. So there's this surgical response that comes in and provides that expertise. Everything kind of gets funneled, hopefully, through the attending and fellow who are leading the call. And then the work, as is mostly being done, is really done by nursing. So, Jessica, you want to kind of touch on? So, we have a few roles inside of the trauma bay. There's 4, 5 if you include the Belmont. You
Yeah.
want to talk a little bit about those?
Yeah, so we have our 4 basic roles. We've got 2 bedside nurses on either side of the bed. In some situations, we have our nurse right on the right side of the bed. Is a tech can function in that role, getting on the monitor, helping get IV access, getting the patient exposed for that exam. Your nurse on the left side of the bed is giving medication, making that rapport with the patient. A medication nurse helping draw up any medications the patient may need, and then your charge nurse who's doing the documentation, helping control the room, and leading it from the nursing side.
Yeah, and that is probably one of the hardest roles because you're kind of playing air traffic controller, conductor, you're documenting. It's a lot and probably takes a lot of experience to kind of like get into that groove of things. And then Joanna, you want to talk a little because we have other nurses that kind of come in to support that. There's when we use our rapid infuser, the Belmont, we always have somebody that's helping with that as well.
Yeah, so there are different roles that can be kind of like an ancillary role that isn't part of the core team. So there's the Belmont nurse who will take charge of running the rapid infuser and also doing the transfusion if the patient is part of the massive transfusion protocol. There's also nurses that will help to be a coach on the Zoll if they are using the Zoll in the code room, and those can be fulfilled by many different nurses, trauma trained nurses in the emergency room, as well as our trustee crisis nurses, as well as our transport medicine nurses. So we have a lot of help in case we are short staffed and need extra hands in the code bay.
Yeah, so the idea, right, is that the resources coming into the code bay kind of, are a response to how much support is needed. So you can call in what you need, you can release what you don't. So all of that structure is super important, right? And I think that's what kind of helps. We have all kinds of structure when it comes to trauma, and all of that is helpful because this oftentimes is what I call a high acuity, low occurring event, a halo event where you need that structure to help remind us how to get those, these essential roles taken care of. But with all of that structure, like what's the point of needing to have this discussion on leadership? I think all of us, when we were training, those of us that are training others, we really focus on the doing and the procedural and the assessment skills because those are kind of what are tied to getting the patient where they need to go. But I think what we're talking about today is super valuable and super important and not always kind of sprinkled into this idea when we're learning about these roles and how they interplay with each other. So we were recently doing some simulation with the PEM fellows, and I talked about how the trauma call is like walking your toddler through traffic, right? There's a momentum that occurs with that. The kid's going to pull you in one direction. You're going to have to pull them back. There's areas you don't want them to run off to. And so finding that balance is super important. We have these ranks, we have these roles, but in each one of them, there's this opportunity to influence the overall temperature and dance of that room. And so I think that's why that's super important. So the first thing I wanted to touch on was this idea of clinical momentum. And Dr. Nickerson, we talked about this with the PEM fellows recently because things can get out of hand quite quickly as they start to escalate or roll downhill. And we talked about, who has control of that momentum, and that control shifts depending on where you are in the process of assessment. In the beginning, that presence from the attending and fellow that kind of outline what we're doing, what our priorities are. It is them who are able to control that momentum, but that quickly shifts as we're trying to, hit the primary assessment, the secondary assessment, and things like that. How important is momentum control in like ensuring that the call doesn't, that the case doesn't kind of go out into left field?
I mean, I think it's the most important thing that's happening in the trauma room. I think if you think about like an orchestra, you have a lot of people who are playing instruments, who know what they're doing, who are amazing at it. But if nobody's telling them when to start, when to stop, when to go, then it's not going to sound good together. And I think that's what the trauma room is like. You get all of these skilled people in the room who know their role and know exactly what to do. But if you don't have someone sort of running the show and making it all happen, then they'll bump into each other, then they'll shout over each other, then they'll poke each other with a needle, quite honestly. You know, it's an unsafe place, the trauma bay. And so at the foot of the bed, you really need to keep control of what's happening to make sure that the right things do happen.
Right, absolutely, and I think the other thing that's important is when you're in that role, you have to stay there. I think we've
Mhm.
seen examples of leaders in whatever role they are moving into a primary role, and all of a sudden the ship starts to drift away from the dock a little bit. You know, I've seen that working in the ICU when I'm the charge nurse and I run in and I'm the first one doing compressions, and then all of a sudden you turn around and there's people on unicycles running down the hallway, right? So it's important when you identify that role that you try to stay. You know, we usually use the term "stay in your lane" as a negative thing, but it is important with the complexity of this workspace that everybody kind of like maintains that control. Go ahead.
Totally. And I think some of that is it's impossible to both focus on an individual task and focus on the room as a whole. And so once you get pulled into a task, you lose the ability to see what everyone else is doing. And there's all these people who are doing specific tasks that need your help to figure out what's actually going on with the other people in the room.
Yeah, for sure. There's definitely there's definitely like a benefit of having that wide angle lens, and I think that's what's beneficial. Even when Dr. Bird and his team come in, they're kind of starting out in that wide angle lens. Anesthesia, if the airway isn't immediately need to be met, they're kind of stepping back from that. So that's super important. The other thing that's important with all of this is the prioritization of tasks. I think nursing is definitely feels the brunt of that because they're being
Mhm.
asked to do 1,000 things. I joke like, you know, it almost feels like you're in like a medical simulation, and you're just like, give me blood, the blood is given. Give me drug, the drug is given. So, Justin, Joanna, what do you guys think about how you prioritize things in your roles? How do you communicate those prioritizations, and why is prioritization so important?
Yeah, I think especially for the medication nurse, when there can be so many things going on that's being asked for in a high situation, that kind of keeping yourself organized over there to know what you need, and then training back to that doctor who's leading the room to kind of, hey, you gave me 6 medications you want given, which one is your priority? Because it's not always the nursing decision making, but being aware of that and your resources in the room to kind of help make that decision. Then as the bedside nurses, you're getting asked to get different equipment and different things that need to be done for the patient, knowing where this equipment is and who you can ask for help in the room when you need it.
I think that's why it's so important for like the charge nurse to be the more experienced nurse so that they can actually pinpoint because they're the ones that know exactly what's going on because they're
You know
documenting
everybody in the room,
this.
you know where
Right, and
everything
they
in the
know
room
everybody
is.
in the room. So if they know something's not being done, they can look to that nurse and be like, "Hey, we need a chest tube being set up. We need nurse XYZ. We need a Belmont. I need somebody to do Belmont." So that they can. There's a closed loop communication, and so they're looking at them in the eye and being like, "Okay, I got this," and there's a communication going on there, so that the tasks are being done and we're prioritizing those that needs to be done first.
Exactly. The surgery team comes in and they know exactly what they need to do, but not who the people are, where the equipment is, and kind of help facilitating getting all of that together so they can do what they need to do.
I think with this kind of like paralleled structure as well, it is super important when you talk about continuing education because it'd be very easy to kind of clump everybody's roles in a box and say, I don't need to worry about, you know, the pathophysiology and the backstory behind, you know, finger thoracotomies in the trauma bay. That's a doctor thing. Or the doctors could be like, I don't need to worry about the Belmont. That's a nursing issue. But it's this idea that we could want 10 things to happen in a matter of minutes, and having a good understanding of each other's roles and the indications is what's going to help the team kind of have that right group think and prioritize what things need to be done first, second, or third. The third thing I think when I think of leadership in the trauma bay is how it affects trajectory. So the idea here is getting patients to definitive care. Luckily for us, they're here. They've come a long way to get here. They're at the right spot, almost 99% of the time. And so we now need to figure that stuff out. So Dr. Burd, when you think about, getting patients to definitive care and that trajectory out, how do you see leaders, both either in surgery or just your work in trauma management as a whole? How does that kind of affect? How does leadership affect the ability to efficiently get people out to the right spot?
Yeah, I mean, I think one of the things is that um, just like it's hard to teach people how to be nice people, it's hard to teach people how to be good leaders. But we can, even though it's hard, we can do things like model good behavior and give some clues about, give feedback to people when we observe good behaviors, and give them feedback when we observe not so good behaviors. But I think that there's different a nice article was recently published in Journal of Trauma that used video review and analyzed different styles of leadership, and identified 3 different styles of leadership in the trauma bay. And the 3 styles of leadership identified, and I think this is probably helpful enough that if people hear this, they can modify their style into one of these styles. The first style is transformative, and this is basically the leader. This is Barack Obama was a physician now in the trauma bay, inspiring people, driving people forward into positive behaviors. Making people do things greater than themselves on a regular basis. So, truly inspirational leader. And I would say that in my career, I've seen very few people who really fit that bill. The next category is leaders that are transactional, and those are much more common than the transformative leaders. And the transactional leaders are those who listen to what people are saying and try to move things along based on, here's what we need to do. Here's the task that we need to do. Did you do that task? And not silent, not necessarily inspirational, but keeping the team moving forward with a common goal and purpose. The third style is the style that we all know unfortunately too well, which is the passive style, which is the person who comes into the room and serves in a leadership role, but they're standing there and they passively react to information, but they're not taking any strong role in moving the team forward. So they hear information and they respond to it, but they're not actively trying to get information or actively trying to steer the team in some kind of way. And when you look at those 3 styles and you look at how the teams perform, and this is the resident staff, the nursing staff, the respiratory therapy staff, the entire team in a room. If you look at how the teams perform, the teams that are led by the transformational leader or by the transactional leader have the best performance. And it doesn't. You would think that the Barack Obama style leader would be steering the team the best, but it really doesn't matter. It just matters that you have somebody that is not passive. It's really non-passivity, which is key to keeping the team members performing their best. It's the passive team leader that makes the team. Not makes the team, but that is the passive team leader that has their teams performing at the worst. So coming into the room and standing there and not vocalizing a plan and just waiting for things to happen is the least effective strategy. And we see this all the time with, an unfortunate situation where we have either people that just by the nature of their personality are passive, or a rotating resident on their very first day, they just showed up at the hospital an hour ago. They don't know anybody in the room. They don't know how things work. They don't know if they should speak up. They're uncertain where anything is. They're uncertain, if they should even take a leadership role. And so the best response that they can come up with is passivity. And that is probably the worst thing they could do. What's more preferable is if they weren't passive. Instead, if they actually took what they knew and tried to move the team forward in a positive way. And I think that's where I think all of us could help support. Paradoxically, could support the leaders in making positive change. And so that's where the emergency medicine physicians can see a passive surgical leader. They need to realize that it's pretty rare that there's a surgical senior who shows up at Children's National without ever having led a team in the trauma bay as a transactional, at the very least, or a transformative leader. They show up. If they're appearing to be passive, it's probably because they're trying to be safe and respectful rather than that's the way that they believe things should be done best. So, having the team be supportive of them and say, listen, you know how to do this. Please do what you know how to do, and we'll support you through this, rather than say, looks like another surgical senior is showing up here and is passive. That's probably not their general approach, and it would probably be just not good for the team to allow them to be that way. And so doing things to say, listen, you're here, you know this stuff well. You've done it many, many times. Just do what you need to do, and we'll steer you the right way for things that are specific to our institution. I don't know if I answered your question, but
no, you nailed it. Yeah. I think the other part to all of that, especially when we're talking about passive leadership, is that the trauma bay is a jungle, right? We're animals. We smell fear. We are type A. And if the person supposed to be leading does not assume that role, someone else will, or a group of someone else's will. And I think that's where we start to see that clinical momentum kind of roll down the hill in almost a deleterious way to some degree. I think back to like some John Maxwell teachings of a long time ago, that leadership is not a rank, it is not bestowed upon you, it is only influence and nothing more. So I remember talking about leadership to lots of like newer nurses, newer clinicians, and they're like, I'm not a leader. What do you call putting that name on me? But everyone has the ability to be influenced in their likeness to provide the level of care that they should. I think we've all have those people that were role models, probably not by title, but by their behavior and the way they carried themselves. And so I think that's super important when you look at the way that the roles are set up inside of the trauma bay, and making sure that you influence each other in a positive light.
And I think Brad, you bring up a good point. Is that we traditionally think of the leaders as the physician leaders or the nurse leaders in the room, but there's a lot of leadership going on in a lot of different ways. So there can be a nurse, a medication nurse, for example, who helps direct an aspect of the patient's and is directing the medication administration and prioritization in a very focused way from that side of the bed. It serves an incredible purpose, and that's not something that the teams, the nurse leader or the physician leaders at the foot of the bed have the bandwidth or ability to monitor. And so there's lots of opportunities for leadership that are not what we traditionally think as leadership in the trauma bay. That if everybody can find that niche to move things forward, I think that the patient benefits from that.
Yeah, absolutely. I think, yeah, I'm not a fan of the old hierarchy status. I think that everyone's disciplines kind of parallel themselves. And so to your point, I think it's a team sport for a reason. Um, any other thoughts on this idea of influence and, leadership by behavior and not by title?
Yeah, I mean, I would say that there have been countless times in my life in the trauma bay where a charge nurse has said quietly to me the next step. Where I've said that to a fellow, where an attending said that to me where I was a fellow. Like, you don't have to be the loudest person in the room to be driving what's going on. And I think that that's where I do a lot of training of fellows. And that's where I see my role of helping them find their voice, even if they're not comfortable. And I think the same thing happens with the surgery team when they come down. I turn to them and ask their perspective, but they don't have to be the one shouting to be one guiding or influencing the care that's provided.
Yeah. I think I don't believe you were in my head because what you said is just like the perfect transition. But you're absolutely right. This, a lot of people take presence to mean volume, and when we've done our PEM trainings, I've told them all, like, if you want to battle that, I will be louder in any role. Like it's less about volume and more about presence. I think is really what it comes down to.
It's attention, right? It's getting people's attention that they're actually listening to you. I have 3 little boys, so it's like I could shout, but they could always shout louder than me. And
Right.
it's really about like sometimes getting on the ground and getting them to listen and talking quieter is actually more effective. And I think the same thing is true in the trauma bay. You just have to find your moment to gather everyone's attention.
Yeah, for sure. I think in talking about volume and talking about being loud or being quiet, I think the other topic that comes to my mind is this idea of the one voice theory. So, you'll hear it from time to time, literally as people are walking the base, someone will shout out, "I need to hear one voice. I need to hear one voice." And I think that's so incredibly important. It almost speaks to this idea of like trauma bay etiquette, if you will. But I think it even starts from when EMS comes to the door. And I think Joanne and I are excited. We're going to reach out to some EMS colleagues for some podcast content as well. But there are two types of EMS patients that roll into your door: patients that are hemodynamically stable and ready for report, and those that are not. And so giving the stage to those EMS providers, one, it controls that momentum, like we kind of talked about inside of the room. It gives the room a bit of a pause, so we're not just start grappling and unstrapping and pulling blankets off and whatever for a patient who doesn't have a life threatening assessment. um, but then it also kind of allows the microphone to be passed from one person to another because you started with that sort of approach. And so, what are people's thoughts on the one voice theory? How is it important? What are your thoughts on it? I think it also helps with a lot of closed loop communication, so that there's one person that's kind of taking this primary, and certainly helps the charge nurse trying to document one conversation instead of 15 little ones.
I think it's just it kind of helps like what you I think one of your sayings now is like tachycardia is contagious in a trauma bay, right? So when you have one voice, it's like everybody's focused on the task at hand, what's being said, the primary assessment, have we completed it? Is there anything we need to go over? Is there anything we need to address? And then we're going to summarize, and then we're going to go on to the secondary summary. But like having that control keeps the kind of like the vibe in the room at an even keel, so that the tachycardia doesn't take over, and so everybody's running around amok and thinking like what they have to do is the most important thing that they need to do, and they can't focus on what's actually happening
Yeah.
generally in the room.
Yeah, I like to. I have a few silly sayings, but that's definitely one of them. The other is that my trash man doesn't come around the corner and see all the trash cans and get real excited about it, right? Like, we are the professionals that are here to do the work, and so maintaining that level of decorum in each person's presence definitely helps with that momentum. Dr. Nickerson, you're going to say something?
Yeah, I was just going to say that I think the more complex, the more sick the trauma patient, the more important it is to follow ATLS. And then also the more voices you get in the room, right? So you have a peds emergency medicine physician, you have a trauma surgeon, you might have a neurosurgeon, you have an anesthesiologist, you have a PICU attending or fellow who's there. And everybody comes from a different type of training, right? So they're like way of prioritizing their exact way of doing things, whether they want to use mannitol or 3%, whether they come from our institution or another institution might be a little bit different. And I think like none of those ideas are wrong, but the team needs one idea. And that's where like agreement from everybody who could make a decision actually creates that one voice. It's not having multiple smart people or one person who's designated, but the ability to communicate through a little bit of disagreement in the setting of a lot of stress of a patient who's really sick is what creates that one voice.
I'm interested to. Oh, go ahead, Dr. Burn.
Yeah, I was going to say, one of the things that we see that people do is that they have a disagreement with what somebody is doing, and so they stand in the corner and issue their voice uh, for some issue. So, like for example, they will say they disagree with the fact that the patient's being transfused or something, and so they'll stand in the corner and yell out, "We shouldn't be transfusing," or "We should be giving crystalloid." And they try to supplant the one voice in the room by giving their opinion about an issue, and that helps like nothing. It doesn't do anything. And now, if you're the receiving, you're at the bedside, whatever role, what you're hearing at the bedside is two different voices giving two different opinions, and the team is just horribly confused. And the solution to that problem is for the person with a differing opinion to simply walk up to the person that they differ with and explain their opinion and give the reasons why. And for whatever reason, the person is uncomfortable doing that or don't want to do that or whatever. And now the team gets thrown into disarray with differing opinions about the same issue. So that's where the one voice is taken advantage of. Is they're trying to make their voice the one voice, and that's a real hazard. And we see this many times where somebody walks in the room or has been in the room and their viewpoints aren't being listened to for whatever reason, and they use their voice to try to overpower the room, and it uniformly causes chaos in the room.
Yeah. I'm curious from like Dr. Nickerson or from Jessica's viewpoint, because we only see this in trauma patients. We only see this dynamic in the trauma patients, but you guys see just as sick and just as complex resuscitations on the medical side. Is the structure of trauma helpful? Are there things that you wish, one side had that the other? I'm just curious because we don't really experience that at all.
Yeah, I think you get a pretty similar environment in a medical alert, especially for your complex kids who have cardiology on board or other services that are coming down to the emergency room. So then you end up with your emergency room team, your PICU team, your cardiac team, all wanting to be the one voice. And if you don't kind of have that same model of these are your roles and who is leading this, you can end up in the same confusing situation where you're hearing multiple things as the bedside nurse and not sure what task you're supposed to be doing.
Yeah.
Yeah, definitely. It happens in other cases, but I think that the trauma structure actually helps us with med alerts because we know how to communicate with other services and we know how to share a mental model with them of what the priorities are and like create a quick relationship. That's my whole job, right? I like never know anybody who walks in the door, but I have to establish a trust that doesn't exist in a really intense setting. And I think that those communication failures actually are based on like lack of familiarity and lack of trust.
Yeah, that's a good point. Yeah, trust is earned, and so just coming in, with a sticker on your chest, it definitely takes a little bit of time to get that. That's a really good point. I think the last thing I wanted to touch on with this idea is just the importance of closed loop communication side of the trauma bay. Again, another aspect of that trauma bay etiquette, and why it is so important. I think we do video review on all of our traumas, and so many times we can hear the room getting louder, and a lot of times we hear the fellow or the attending that's running the resuscitation say, like, where are we with the primary, where are we with the secondary? And so again, I think closed looping communication, even though it sounds a little like yes chef kind of thing, it is super helpful. And I did make that reference and I'm sticking
Yes,
to it.
that's my
um,
favorite reference there is.
there
I'm
you
with
go.
you.
So I mean, like, this yes chef idea is helpful. Like knowing that the primary has been completed, it almost can feel robotic. But I think from Jessica's staff acting as the charge and like trying to ensure that we've hit all the parts and whatever, that they've been appropriately communicated and documented, but also knowing where we are. I just think it's so influential, and it also helps create a cadence and kind of keep that momentum in play there. Any thoughts on closed communication challenges and thoughts on the trauma bay?
I think doing some video reviews and then also being one of the bedside nurses or having experience being a bedside nurse in the trauma bay, it's very confusing and can get very chaotic when there are multiple people shouting out multiple orders and they feel like there's a lot of like, we need hypertonic, we need blood, we need did we get a blood pressure, what's our status on labs, and then it's kind of like shouted out into the room, into like the dark abyss, and nobody actually receives it, right? So it's just said, it's only been like said, but nothing has been received. And like I think the because of the nature of the chaos in the room, there has to be kind of a response like, I got that, and then kind of giving notification like through eye contact or whatever it may be, saying like, I will get the labs. I will do lines. I will do the transfusion. I will do, so that there's some sort of responsibility and there is actual somebody identified who's going to complete the task. And then like kind of going back to your sim, it's not just being done and it's done when just because you said it, right? But somebody in doing the work and somebody is actually getting that completed. But closed loop communication is, I think, essential in the trauma bay to make sure that chaos doesn't ensue.
Right, and like the one way to ruin closed loop communication is multi loop communication, and so we have so many. We're so lucky at Children's National that we have so many specialists that are able to come right downstairs. Neurosurgery, anesthesia, trauma surgery. All these people are coming in, but one thing we have to remember is that even though we all have uh, observations, there's one true leadership role in that bay, and everything really needs to be funneled through that one person. So if I'm neurosurgery and I see there's brain matter on the floor and we need to get up to the OR, exclaiming it to the abyss, to use Joanna's terminology, is not as helpful as making direct eye contact with that EMTC fellow and saying, we have a surgical emergency here. I need to get upstairs, and allow that person to establish that priority to the group. Any other ideas on closed loop communication? Otherwise, we'll wrap things up here.
I think Dr. Nickerson had something to say.
Yeah, all I was gonna add was what you just threw out there, Joanna, was actually like examples of a leader needing to do better closed loop communication. Because I actually spend a lot of time with the fellows talking about this, is not only do you need to direct it at somebody, but you need to say with confidence that it needs to be done. And I think as new fellows are coming in, they're feeling overwhelmed at the foot of the bed, and they're not sure, like, do we need labs, we need this, we need that, and they don't know the people that well, and so there's a lack of confidence that comes. But I think better communication is, Joanna, can you please establish a line and draw labs? After that, we'll give this medication. I think we need both direct communication and prioritization to make closed loop communication happen.
Yeah, that's a good point. We actually learn a lot of this type of sociology through the aviation industry.
Yes.
This idea, this crew resource management, the CRM stuff from when I was a flight nurse is very important. That's why we have things like checklists and things
Mhm.
like that, which can all feel again like robotic in a way where like I don't need a checklist to remind me how to do X, Y, or Z. But in reality, we've learned that making high stress decisions that have very high consequences need this sort of structure. In aviation, when we're in critical stages of flight, namely taking off and landing are the two probably important ones, we actually will call out that the cockpit is sterile. It's a sterile cockpit. It allows us to be quiet and to focus on that task. And a lot of we can learn a lot of this type of stuff through what aviation has done, and we are implementing a lot of it. We have checklists and things like that, not as a support for competency, but we know that when we're in these high risk environments, the ability to recall things under stress is a challenge. So all right. Well, we're wrapping things up here. I think what we'll do to kind of end close for today is just if everyone wanted to give their one piece of wisdom. You're all mother hen, and you all are teaching the next generation in your role as an attending, as a surgical specialist, as a nurse. Like, what is your one piece of advice for being a leader in that bay? And we'll start with Dr. Burd.
Don't be afraid to lead. If you're everybody was afraid at one point, don't be afraid to do it.
Good one. All right, Joanna, what you got?
As a charge nurse, you can command the room. You can ask people to leave. You can have people to do things and assign roles. So take that role seriously, and please kick people out that don't belong there. It's another thing that's something you can also do.
Very valid. All right, Jessica, what are you thinking about?
I think as the charge nurse in the room, you are running the room. So you are helping people know where things are, helping decide who needs to be in that room, and keeping volume under control. That way you can hear what's going on, you know what medications are giving, and you're working with those doctors to lead the room.
Absolutely. Dr. Nickerson.
I would say the first step is to know the big bucket that the patient falls in. Like, are they in hemorrhagic shock? Two, to share that with the room so everybody has the same mental model as you. And three, to guide the room with what's the most important priority for right now.
Absolutely. When I think of leadership and being a leader, regardless, I think back to one of my mentors, Simon Sinek, who I think it just is so smart when it comes to this stuff. And he says, leader, you don't become a leader because of who you are or what you're a part of. You become a leader because you are making an active intention towards taking care of the person to the left of you and taking care of the person to the right of you. And I think it's so important when you're thinking of both mental health and healthcare, but also in treating our patients that are members of our community. It's just so important to remember that really is the definition of being a leader, and so thankful to be alongside all you guys here at Children's National. And I think with that about does it for our time. We look forward to another episode. We'll be putting out a link at the end of the way here for some CME for nurses. Until next time, we appreciate you all being here, and we'll see you soon.